All right. So this is chapter 36. Welcome back to COAG. It's been a while, I feel like. Um, and we're going to talk about bleeding disorders and their lab assessments. And then in the other chapter, chapter 38, we'll talk about thrombocytopenia and some of the causes of thrombocytopenia. As you know, what that means is a decrease, right? A drastic decrease in the platelet count. So let's talk about some bleeding conditions. There are some acquired bleeding disorders and some congenital, so inherited bleeding disorders. Acquired disorders are here, so we'll talk about some of those. We'll briefly talk about trauma-induced coagulopathies. We'll talk about liver disease, DIC, chronic renal failure with bleeding, vitamin K deficiency and hemorrhage, and the issues with acquired von Willebrand's disease and autoanti-factor VIII inhibitors. And then we'll talk about some inherited disorders. So von Willebrand's a big one. We'll talk about the different types of von Willebrand disease and hemophilia. There's another big umbrella there that we need to cover for bleeding disorders, inherited bleeding disorders. So bleeding disorders can be disorders of primary or secondary hemostasis. So for example, von Willebrand disease and platelet disorders are considered to be conditions of primary hemostasis. And platelet disorders can be qualitative or quantitative. Quantitative platelet disorders involve thrombocytopenia, and qualitative involve the platelet issues with the function of the platelet. On the other hand, inherited and acquired factor deficiencies are considered to be more of the secondary hemostasis disorders. So they're a little bit more harsh, I would say, and there's a difference between them. So let's talk about some terms that we just need to know before we start this lecture. Localized bleeding is bleeding in a single location, and generalized bleeding is basically bleeding from different sites or multiple sites. It could be spontaneous, it can be recurrent type of bleeding, and it requires physical intervention and transfusions to basically save the patient. So in terms of bleeding symptoms or what the patient would experience with conditions that are related to primary hemostasis, the patients can experience more of mucocutaneous bleeding. So it's like issues with the skin. So bleeding into the skin, basically, where you can see it, you can physically see it, right? So petechiae is a form of bleeding. They're like little tiny, they express as little tiny pinpoint hemorrhages in the skin. Purpura are hemorrhages into the skin. They're usually a little bit larger in size, larger than petechiae. And ecchymosis are larger, much larger hemorrhage into the skin. So it could be larger than 1 centimeter in diameter. But of course, in primary hemostasis, issues with primary also bring other symptoms than mucocutaneous bleeding. Patients can experience gum bleeding, menorrhagia. Menorrhagia is increased menstrual flow. Hematemesis. Hematemesis is when a patient vomits blood, and epistaxis. Epistaxis is a nosebleed, basically. And so with this, it's more common in people can bleed from their nose, and it doesn't necessarily mean that they have a bleeding disorder per se, and it's common in children, right? But it's not normal if it's happening all the time. Okay, so if it's recurrent, then that's something that we need to pay attention to. And some symptoms with secondary hemostasis are a little bit different, more difficult to basically treat and balance, and something that we need to pay attention to. So patients with disorders of secondary hemostasis can experience anatomical or soft tissue bleeding. Soft tissue bleeding. So anatomical bleeding is really bleeding into the organs. So it becomes a more complicated thing. And this can happen after surgery, trauma, or even a tooth extraction. And these patients tend to bleed excessively. Patients can also experience internal bleeding, so bleeding into the joints. That's also known as hemarthrosis, bleeding into the muscles, the organs, or body cavities. And patients tend to experience recurrent bleeding episodes when it's more related to secondary hemostasis. So what's primary and secondary? Well, primary is related to platelets, right? And secondary is more related to the coagulation factor. So any type of factor deficiency, and most of those factor deficiencies are inherited, right? So there's going to be bigger issues, bigger symptoms to deal with. Oh, so here's these pictures are from your textbook. On the left, where you see A, that's the form of petechiae. So that's bleeding into the skin. That's pinpoint hemorrhages, about 1 millimeter in diameter, very, very tiny dots, red dots, or kind of purple dots. In picture B, at the top right, what you're seeing is more like purpura, so larger bruises, okay? And ecchymosis are really what we called bruising, okay? So ecchymosis on the bottom would be considered a bruise. Purpura is too, but sometimes they tend to be a little bit smaller. And so they're all signs of bleeding, of mucocutaneous bleeding. All right, so how do we diagnose these acquired versus congenital? Well, bleeding, the type of bleeding that the patient is experiencing is very important. So that's what we need to look at. But before we do any of that, the patient history is going to be number one, right? So the type of bleeding is part of the patient history. So this is where the physician will find out if there has been any bleeding in their childhood, any history of bleeding in the family, any history of bleeding after minor surgery, bleeding in other family members. Also, the types of medications that these patients are on, that's very important. And whether they have any underlying conditions. Underlying conditions are number one too, because that could be causing the bleeding, right? So let's get that out of the way and find out what is the real cause here. A physical exam would be probably most likely entail the visual examination of the patient's skin, right? So they'll look at whether there's petechia, purpura, ecchymosis, whether there are issues with the joints, joint deformities, and things like that. And so obviously they'll do the vital signs, right? So the heart rate, the pulse, they'll take a look at all of that together. After the history is done, the physical exam is done, then we move on to lab tests, because the lab tests are really going to be the important part here, where we can tell what's going on with the patient, right? So the initial lab tests, very quick. I mean, if you're talking about a CBC, we're probably going to run a CBC, which entails a white cell, red cell count, a hemoglobin count, a hematocrit count. Hemoglobin, hematocrit are two signs or two parameters that we look at when we think the patient is bleeding. We've got to look at the hematocrit and the hemoglobin, okay? We can look at a parameter called the retic count. You probably haven't heard of this yet. Maybe you have, maybe you haven't. We'll really talk about it in hematology. But the reticulocyte count is just an assessment of the release of immature cells into the bone marrow. And so it tells us like the bone marrow is working a little bit harder to compensate for something. Usually it's compensating for anemia, okay? So then you see the retic count. We look at the retic count, we look at the platelet count, obviously, because the patient's bleeding. We want to take a look at the platelet count. And then routine coag tests, which are the PT, the APTT, perhaps the thrombin clotting time. You can look at the fibrinogen counts or a fibrinogen assay. So some of the tests here may vary, some of the tests that you want to assess. So primarily with primary hemostasis, we're looking at platelet issues, right? So the platelet count is going to be very important. So issues with primary hemostasis will definitely affect the platelet count and platelet function. Now, the platelet function analyzer test and the closure time, yeah, you can do that too if you have it available. But it's not the only test that we're going to do to assess platelet abnormalities, right? We have to do more like platelet aggregation testing. So that would be something that we would do for primary hemostasis. Bleeding time, forget about the bleeding time. We don't even do that anymore. But in secondary, the PT, the APTT, and the thrombin clotting time or fibrinogen would be nice assessments to start with, because that's more related to coagulation deficiencies. Okay, so let's take a look back at your routine coag test, right? PT, APTT, thrombin clotting time. So you know what the PT is testing for. You know it's testing for deficiencies in the common pathway and the extrinsic pathway, primarily factor 7, right? Coumadin, direct thrombin inhibitors, and some direct factor 10A inhibitors, okay, will be able to monitor that using the PT. Remember that polybrine is added to the reagent, so that the PT reagent neutralizes heparin. So if a patient is on heparin, it doesn't affect the PT, okay? With the APTT, you're testing for deficiencies in the common pathway and also in the intrinsic pathway, okay? And we use that to monitor perhaps unfractionated heparin. You can monitor Coumadin and warfarin in some instances, direct thrombin inhibitors, and some direct factor 10A inhibitors. Okay, if it's important to keep in mind if there is a deficiency in factor 12, PK, prekallikrein, and high molecular weight kininogen, there is no significant bleeding that is happening with the patient, but it will prolong the APTT. The thrombin clotting time is checking for deficiencies in factor 1, which is fibrinogen. And so in these conditions, there are fibrinogen conditions like afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia. So these are different fibrinogen disorders. Afibrinogen means that there's no fibrinogen present. Hypo, there's a decrease of fibrinogen, and there's a dysfunction of fibrinogen, okay? So the thrombin clotting time would be helpful to determine issues with that. So we remember Coumadin, unfractionated heparin, okay? So Coumadin, it's the warfarin, which is taken orally. It's a very common anticoagulant. It's a vitamin K antagonist, right? And we know it affects factor 2, 7, 9, and 10, but also our regulatory proteins, which are protein C and protein S. We need protein C and protein S. When a patient is on Coumadin, you cannot assess these proteins because you know they're being affected. These are also vitamin K dependent proteins. These anti-Coumadin and warfarin will prolong the PTT, but not affect, not so much the APTT, but not the TCT, okay? So just keep that in mind. The heparin and fractionated heparin, remember it catalyzes antithrombin, inhibits certain factors. It prolongs the APTT and the TCT, but not the PT, since the PT has the polybrine heparin neutralizer. Oral direct factor 10A inhibitors will inhibit factor 10A, and that's in the name, and they may prolong the PT and or the APTT. And direct thrombin inhibitors, DTIs, inhibit thrombin directly, okay? So that's something to keep in mind because the patients could be on anticoagulants. So when you're testing, it's important to know what they're on and what these anticoagulants are doing. So now we'll talk about some of the acquired bleeding deficiencies, and then we'll get into the inherited or congenital bleeding deficiencies. So one of the deficiencies in bleeding that is talked about is trauma-induced coagulopathy. And the incidence in here, well, it occurs because of unintentional injury. And it's one of the leading causes of death in individuals of ages 1 through 45. In the USA alone, the trauma, okay, so what happens is that most patients experience this kind of acquired bleeding that is secondary to trauma. Some sort of trauma happening, and there's bleeding that occurs because of that trauma, okay? So it could be trauma, but it could also be some sort of exposure, drug exposure, or a disease that's leading to increased bleeding, okay? In the US alone, trauma caused 214,000 deaths per year in 2015. About 20,000 patients die of hemorrhage within 48 hours. TIC, or trauma-induced coagulopathy, accounts for most fatal hemorrhages. About 3,000 to 4,000 of these can be preventable. So TIC is triggered by a combination of injury-related acute inflammation, platelet activation, tissue factor release, hypothermia, acidosis, hypoperfusion, which is poor distribution of blood to the tissues, which all lead to systemic shock. Okay, so all of these, okay, can trigger trauma-induced coagulopathy, eventually leading to what's systemic shock. So the entire body goes into a state of shock. So in these instances, there's massive transfusion protocols that are basically needed, and they need to be administered right away because the patient is bleeding to a very severe degree, right? And so at this point, we're talking about transfusions, not of like one little bag, but perhaps many bags that are coming in one after the other, one after the other. So we know that massive transfusions in these cases are needed when there is a drop in the blood pressure, the pulse gets increased, there is an issue with the pH, it's less than 7.25, the hematocrit is low, the hemoglobin is low. The hemoglobin and the hematocrit are going to be key indicators in this particular instance, okay? So if hemoglobin and hematocrit are lower, okay, the hemoglobin lower than 10, and the PT is prolonged, then we know that massive transfusions are needed. So this would be transfusions of 3 units within 1 hour and 8 to 10 minutes within 8 to 10 minutes, 8 to 10 units, within 24 hours. Okay, so this is a protocol that we must follow in cases where patients are experiencing this severe type of bleeding. And this bleeding, this drop in blood within their body can lead to systemic shock, which is fatal, okay? All right, another condition that also relates to bleeding is liver disease, okay? And we all know why. It's because our coagulation factors are made in the liver, right? And so there's many different types of liver disease. This is like a big umbrella for different conditions, okay? But the type of bleeding could be localized bleeding in one area or generalized bleeding. Patients can experience mucocutaneous bleeding or anatomic bleeding as well. Mucocutaneous bleeding occurs in liver disease-associated thrombocytopenia, and also there is decreased platelet function. Okay, so again, major site of coagulation factor. So this is what we're making a coagulation factor. So this is a big deal when the liver is not functioning normal, it's not making coagulation factors. So one of the first things you're going to see is issues with the routine coag tests, which are the PT, the APTT, and the thrombin clotting time. These are all going to be affected. Factor 5 and factor 7 are severely affected. Factor 7, as you know, has the shortest half-life, right? And in early liver disease, the PT is the only test that will be prolonged, and that's because of factor 7, because factor 7 has a short half-life. So that's one of the first factors to start becoming decreased, and we will reflect that in the PT test. So in early on, you may not see the APTT or the thrombin clotting time be prolonged, but you may see that the PT is prolonged right away. Something to keep in mind is that the fibrinogen, factor 8, and factor 13 are considered acute phase reactants, and instead of being decreased in this particular instance, they may be increased. And if they are, it's probably due to the inflammatory process that is happening within liver disease, okay? Again, there's many types of liver disease many types of disorders that can affect the liver, right? We're talking about cancers, we can talk about hepatitis, right? Liver cirrhosis. So all of these things, no matter whichever one it is, if there is an inflammatory process, you may not see that there is a decrease of the fibrinogen or factor 8 or 13 right away. Instead, they may be increased. And that's because they kind of like flip when there is an inflammatory process. They're acute phase reactants. Now, you may see them decrease or you may see them in normal amounts as well. In liver disease, dysfibrinogemia may also occur, and this is a dysfunction of fibrinogen. The platelets may be normal, may be decreased. There's also a decrease in antithrombin, protein C and protein S, okay? This can also lead to the activation of DIC, in which you will see an increase in the D dimers. So what we do here in liver disease is we use the decrease in factor 8 and factor 7 to our advantage. Okay, so factor 5 and factor 7. Factor 5 and factor 7 assays are used to differentiate liver disease from vitamin K deficiencies. Okay, because they're a little bit similar, not always, but we can confuse the two. And so we look at doing assays for factor 5 and factor 7 to differentiate liver disease from vitamin K. Both factor 5 and factor 7 are decreased in liver disease, but factor 5 is not decreased in vitamin K deficiency. Okay. All right. So the next condition is liver disease and DIC. So there is the triggering of DIC because of liver disease and everything that's going on with liver disease. And that's can totally happen, right? So we know disseminated intravascular coagulation is a very serious condition. We know it is called consumptive coagulopathy, and this is a condition in which there is clotting and bleeding at the same time. So DIC, it could be a complication of liver disease. So there is obviously a decrease in the production of antithrombin, right? So remember what antithrombin is. Antithrombin is a regulator. There's a significant decrease in protein C because of liver disease, protein S because of liver disease, right? And also, all of this can activate some procoagulants and release activated procoagulant proteins from degenerated liver cells. So all of this can trigger DIC in a person who has severe liver disease. And now, because the liver is non-functional or whatever the case may be, it's unable to clear these activated coagulation factors. Also, there's activation and also consumption of clotting factors and platelets. So you'll see the lots of factors become consumed in the clot. Platelets can get consumed in the clot. There's the activation of the fibrinolytic system. In this case, plasmin digests the right? So there is constant activation of fibrinolysis as well. So in DIC that is related to liver disease, we see bleeding and clotting, okay? And most of the time, this is fatal, all right? So we know that DIC can be triggered due to different things. Liver disease is one of the things, but what attributes, what comes with that are all these pathological pathways that just get activated, right? So basically, because of liver disease or because of inflammation, you can get tissue factor release into the circulation, right? You can get tissue injury, exposure to the subendothelium, endotoxins, toxins, platelet activation. All of these cause DIC. So whatever the issue is with the liver, you know, again, whether it's hepatitis, whether it's cancer, it's causing obviously, because it's such a major site of coagulation factor syntheses, that it will cause a series of things to happen. So just by having a decrease in the production of antithrombin, protein C, protein S, all of that is an issue in and of itself, right? So So DIC can be triggered by, again, tissue factor release into the circulation. And again, malignancies, trauma, tissue damage, that can all happen in liver disease. Tissue injury, okay? There is a release of particulate matter into the circulation, exposure to subendothelium. All of these can be related to liver disease, and it could cause a DIC. So DIC, again, is a big complication of liver disease. So we know in DIC, so when the patient gets to this point, we know that the routine coag tests are going to be affected. You'll have a prolonged PT, APT thrombin clotting time, a decrease in the fibrinogen. You'll have platelet counts that will be decreased. The D-dimer will be increased. The soluble fiber monomer will be positive. Factors 2, prothrombin, factor 5, factor 5, factor 8, factor 10 will be decreased. There will be anemia because there is clotting, and the anemia is actually coming from the microthrombi that are being formed within the small vessels. And as the blood is trying to flow through, it's breaking up the blood. It's causing the formation of schistocytes, and that's causing anemia, right? Because it's breaking up cells. So when you break up the red cells, that's going to cause anemia. And that happens in about 50% of the cases. Okay, so we all know that it's important to know that D-dimers can be increased in other conditions as well. It's not the only test that we're going to use to diagnose DIC. We have to use a series of tests. DIC is a very helpful one. I'm sorry, D-dimer is a very helpful one, but it's not the only test that we can use. So we talked about this last time when we explained DIC and the formation of schistocytes because of the microthrombi that are being formed in the vasculature. And these are your typical red cells. I mean, they're not normal, obviously, because they would look like it would have like a nice central pallor, and they'll look salmon in color, right? This is kind of like a bigger cell right there, and it looks a little bluish in color. This is more of like an oval cell, looks a little darker in color. So obviously there's some abnormalities here that we're noting, but for the most part, what you're seeing is that there's like pieces, right? These are pieces of red cells. And that means that they're fragmented, they have been broken. These are called schistocytes. And it happens a lot in people that have DIC because of these breakage of red cells. And this is also another cause for the anemia that's occurring. So the issue here, okay, in DIC, okay, is that there is clotting happening, but bleeding could be very severe and fatal. So when there is enough massive bleeding going on, the patient can go into systemic shock. And so here are some treatments to resolve liver disease-related hemorrhaging. And so, well, we know that liver disease is the underlying cause that's really, the liver is really damaged. There's an inflammatory process happening. It's eventually leading to the triggering of DIC. So what can we do to treat this particular condition before it's too late, basically, right? So we can do our oral or IV vitamin K therapy to correct for the bleeding that's related to non-functional factors, factor 2, factor 7, factor 9, factor 10. Those are the vitamin K dependent factors, right? But vitamin K therapeutics are short-lived. So we may also think about doing some plasma transfusions, because remember, plasma is a component of the blood. When you separate it, the plasma will provide coagulation factors, right? So it'll provide coagulation factors. These are donated plasma. So these are normally people that are normal in their levels, right? So when you are able to separate the blood and take the plasma out, run that plasma, test it, right? It's ready for retransfusion into another patient, right? And so what that plasma is going to do is it's going to provide a lot of factors, a lot of proteins, okay, to help boost our patient, okay? So plasma can provide all of the coagulation factors in hemostatic concentrations. What that means is in normal levels. So 1 unit of plasma can provide a volume of 200 to 280 mLs, and the typical dose for adults with liver disease is about 2 units that can get transfused into them. Okay, if the fibrinogen level is very, very, very low, okay, spontaneous bleeding is imminent. Okay, so we can give cryoprecipitate or fibrinogen concentrate. And again, cryoprecipitate and fibrinogen concentrate are components that we can make in the lab, in the blood center. Okay, so again, it's coming from your blood, coming from normal patients. Okay, we can separate all of this and make this specific components for these kinds of diseases, for these kinds of issues. So we have it ready so that it can be ordered and then it can be transfused. Okay, so cryoprecipitate is really a component that has a lot of protein, and fibrinogen concentrate is the fibrinogen. Whether it's most of this is manufactured, the fibrinogen concentrate, and so it could be given to the patient to boost the fibrinogen levels on the patient. Other treatments are platelet concentrates. Okay, PCC stands for non-activated prothrombin complex concentrate. Okay, so there's a series of concentrates that can also be given to the patient. There's also antithrombin concentrate. You have recombinant factor 7-8, which is activated factor 7, and TXA. TXA stands for tranexamic. I should put it in the slide next time. Tranexamic acid. Okay, so this is an antifibrinolytic lysine analog. And so all of these are just options in other treatments that can be given to the patient. If plasma itself doesn't work, we can move on to giving them concentrates, or you can give them concentrates with the plasma. Another issue in acquired bleeding deficiencies is having chronic renal failure and bleeding, right? So chronic renal failure, it's also obviously very, very dangerous. We know the kidneys are very important. You've been learning a lot about the kidneys in your analysis. The type of bleeding that a patient would experience is associated with platelet dysfunction and mild to moderate mucocutaneous bleeding. So there's issues with the platelets functioning correctly, and also you would see bleeding into the soft tissues. The platelet abnormalities that you would see here are issues with platelet adhesion to the blood vessels, and platelet aggregation is suppressed. So platelets tend to become coated with what's called guanidinosuccinic acid. Okay, and so that is basically stopping the platelets from being a part of the aggregation process, okay, because they're coated with this protein, with this acid. There's also a decrease in red cell mass, which it's also known as anemia. There's thrombocytopenia that also occurs that contributes to the bleeding, okay? Now, it can be corrected in certain instances with dialysis and EPO or red cell transfusions. EPO is erythropoietin, which is the hormone that erythropoietin is the hormone that is made in the kidneys, but it acts in the bone marrow to make more blood cells. Okay, it acts to make more red cells. So some syndromes that have been associated with this are DIC and hemolytic uremic syndrome, HUS. There's also thrombotic thrombocytopenic purpura. All right, so with HUS and thrombotic thrombocytic purpura, they deposit fibrin in renal vasculature, okay, and then they reduce the function of the glomerulus. All right, so then that could aid, or that can, you know, add to the issue and cause more hemorrhage, more bleeding. So in terms of a lab test, PTs, the APTT can be normal. The bleeding time, which we don't do anymore, that's prolonged, but the platelet aggregometry results can predict some bleeding. So we know that the platelet aggregation doesn't function as well here in these instances. And so we can do some platelet aggregation testing. The management of this condition focuses on the severity of bleeding. And you can use renal dialysis to correct that. And you can do the administration of desmopressin acetate, DDAVP. AVP is a concentrate. Again, it increases plasma bound Willebrand factor for platelet adhesion and also aggregation. So that may help a little bit to correct the bleeding. Another acquired condition is vitamin K deficiency, right? And its relationship to bleeding. And so we know vitamin K is needed for the gamma carboxylation of glutamic acids at the end terminus of factor 2, 7, 9, and 10. Vitamin K comes from green leafy vegetables. It also comes from the bacteria in the gut that is making vitamin K. Without vitamin K, we have these factors that lack the gamma carboxylation. Therefore, they cannot bind to calcium and they are not functional. The test in vitamin K deficiency will show a prolonged PT and a PTT. In early vitamin K, you would see a PT alone being prolonged only because the factor 7, right, is it's the one that gets affected the earliest because it has the shortest half-life. In this case, though, the thrombic clotting time is normal, okay? With factors 2, 7, 9, 10, you have definitely some decrease in activity. But again, factor 7 is the first factor to decrease because of its shortest half-life. So vitamin K deficiency can be found in different conditions. So one of them is hemorrhagic disease of the newborn. So bleeding disease of the newborn, you can see vitamin K deficiency in fat malabsorption. So people also may have a deficiency in which they can't absorb fats. And so they can't take in that vitamin K. Malnourished patients that are on prolonged antibiotics. So antibiotic administration is very important for vitamin K because antibiotics, when you're on it for a long time, it depletes the gut flora the flora that you have in the gut that it's supposed to be making vitamin K. And so when you're on antibiotics for a very long time, well, you can get hit with other conditions because you're wiping out your normal defenses, right? So for us, in COAG, our normal defenses in the gut are very important because they make vitamin K. And so if you have a patient who is not eating well, okay, and is on prolonged antibiotics, then you know they could be vitamin K deficient. All right. So for vitamin K deficiency, you can do an oral intravenous vitamin K. You can have, you can monitor these, right? So you can monitor vitamin K deficiencies and you can give oral vitamin K and see how that does for your patient eventually. So you can monitor, again, look at the PT because the PT primarily takes a look at the factor 7. And factor 7, once vitamin K is in the system, the liver will make more it would make functional vitamin not vitamin K, factor 7. You can give activated or non-activated PCC for factor PCC, recombinant factor 7 that can be administered in emergency bleeding situations. So recombinant factor 7 is actual factor 7 that is given directly to the patient. Activated factor 7, actually. So hemorrhagic disease of the newborn that's caused by vitamin K deficiency. It's a condition that we need to be aware of. Newborn babies are constitutionally vitamin K deficient, right? Because they have sterile intestines. So babies, when they're born, they have sterile intestines and there's not a lot of gut in their flora that's making vitamin K. So they're already vitamin K deficient, okay? So hemorrhagic disease of the newborn was actually something that was more common in the US back in the 1960s, before we knew how important the administration of vitamin K was. So that was before there was routine administration of vitamin K to infants. Okay, so that was actually legislated back in the 1960s when it was found to be an issue. Hemorrhagic disease of the newborn was actually an issue. And now it doesn't really happen anymore, but it does happen in developing countries where they don't have access to the type of healthcare that you may have access to here or in other, developed countries. Factor 2, factor 7, factor 9, and 10 also are lower in newborn babies than they are in adults. So that's something to keep in mind. Premature infants have even lower concentration, and breastfeeding prolongs the deficiency, the vitamin K deficiency, because there's passively acquired maternal antibodies that delay the establishment of gut flora. So the mother is constantly given antibodies, passing the antibodies to the baby. So the immunity is not coming from the baby, right? So that's kind of like delaying the baby being able to establish their own gut flora, their own normal gut bacteria that will make that vitamin K. So again, there's again, not a huge issue here anymore, but if you ever come into a newborn baby with bleeding deficiency, this is something that you could think about, because infants are already deficient in vitamin K. All right. So, and again, it could be, you hardly ever see a newborn baby having, abnormal routine coag tests or abnormal bleeding unless it's a congenital issue, right? Because if it's congenital, you tend to find it a little bit faster. If it's acquired, you don't really quite get to see it. But this is some of the diseases that you may see as an acquired condition. So what this is here, just to remind your mind about Coumadin and what vitamin K does. Remember, Coumadin is a vitamin K antagonist. It disrupts the vitamin K epoxide reductase and vitamin K quinone reductase reactions. In this situation, the liver releases dysfunctional D-gamma carboxyl factors 2, 7, 9, 10, protein C, protein S, also protein Z. I don't mention protein Z a lot. So these are the vitamin K deficient proteins, vitamin K deficient coagulation factors. Okay, so just to refresh our mind. The other condition is the formation of the autofactor VIII and acquired hemophilia. So auto anti-factor VIII, what that sounds like an antibody, like an auto antibody, auto anti-factor VIII. So it's an auto antibody that's being produced against factor VIII, right? So this is also known as acquired hemophilia, because now the hemophilias, there's I'll talk about them later, but the hemophilias are inherited bleeding disorders, and there's different types, but the most common ones that we see are hemophilia A, hemophilia B, and hemophilia C. And what's happening here, they're mutations that occur, okay, in which it lowers the amount of factor VIII, that's the factor VIII or factor 9, that is, or factor 11 that is present in the patient, but it's a genetic mutation, okay? Acquired hemophilia is not, okay? But the condition is called acquired hemophilia because something is sort of like resembling hemophilia, okay? And in this particular instance is auto anti-I, which is an auto antibody formed to factor VIII. And it occurs at a 1 person per million people per year, okay? So not super common. These are non-hemophilic patients, non-hemophilic, that can acquire antibodies to certain factors. So they can actually acquire antibodies to factor 2, factor 5, factor 7, factor 11, factor 13, and McWilliams factor, okay? But auto anti-factor VIII is a common antibody that's formed. So auto anti-factor VIII is the most common one, okay? And the development of auto factor VIII is diagnostic of acquired hemophilia. So when we know the patient has the auto anti-factor VIII, then we know the patient could be said to have acquired hemophilia, not congenital, okay, because that's a whole nother thing, but acquired because it resembles the condition. And here patients are usually older than 60 years old and usually don't have any underlying conditions. But this is an antibody, it's an autoantibody. It could be produced due to some autoimmune disorders like rheumatoid arthritis, systemic lupus, okay? Some people that have inflammatory bowel disease or lymphoproliferative disease will have the formation of this autoantibody to factor VIII. Pregnancy can also trigger this kind of condition. So this you would see it in younger women of childbearing age. And you would know it's acquired hemophilia because an autoantibody has been produced about 2 to 5 months after delivery, okay? So the symptoms are sudden and severe bleeding in the soft tissues and bleeding in the GI tract or the genitourinary tract. And it can be fatal in about 20% of cases. So we know, again, this is an autoantibody. It could be released due to different conditions. And one of the big conditions is the patient having it. Sometimes they have no underlying conditions. Sometimes they have an autoimmune related condition that's triggering this. Some CLAB-based assays that can be used to detect acquire, obviously your routine tests like PT, PTT, thrombin clotting time, with auto factor VIII, auto anti-factor VIII. Well, this is an antibody that's attacking or attaching factor VIII, right? So obviously your PTT is going to be prolonged, but you may not see any issues with the PT and the thrombin clotting time. If you did a factor assay, you will see that factor VIII activity would be less than 30%. If you did a mixing study, you will see that there is a prolonged APTT that is corrected initially by the addition of pool normal plasma, but the PTT is prolonged after incubation, okay? Factor VIII autoantibodies are time and temperature dependent, and the inhibitor effect occurs only after the patient's inhibitor, the antibody, is allowed to interact with the factor VIII in the pool normal plasma. So it will happen, it will react after that incubation period. So that's how you know this is some sort of factor antibody that's attaching, some inhibitor, okay? Now, again, you can have those immediate acting inhibitors like the lupus anticoagulants, or you can have inhibitors that take a while. But so most of the ones that take a while to come out are those antibodies to factors. Now, there's a test called the Bethesda assay. Bethesda, I believe, is a city, and it's called after the city where this test was created, and it measures these inhibitors and it helps choose the correct therapy to control the bleeding. I don't really go too much into the Bethesda assay, but in the textbook, there's a nice section on it, so you can read about it in the textbook for sure, chapter 36. And so how do we manage? Well, activated PCC, recombinant factor 7, recombinant factor 7, activated factor 7 will bypass that factor VIII inhibitor. So it's a good therapy. Sometimes immunosuppressive therapy, once the bleeding is controlled, depending on the condition and what triggered this, depending on what's going on with the patient. But immunosuppressive therapy will also control that antibody from attacking the factor. So, and about just a little side note, occasionally 15% of these types of inhibitors are called high avidity inhibitors, and they may immediately prolong the APTT. So then it can get a little bit confusing, especially when you're doing a mixing study, because you're expecting these to take a little while, but about 15% of them can react immediately. So that's why we have to, go through all our algorithms and our testing. And once we kind of suspect, a lupus anticoagulant or a factor, autoantibody, you still take it for further testing, okay? And our last condition for acquired, bleeding disorders, right? It's called acquired von Willebrand's disease. So acquired von Willebrand's disease is a condition, right, that's very similar to the typical von Willebrand's disease, which is the inherited or the congenital von Willebrand's disease. And it has been described in people that have hypothyroidism, people that have monoclonal gammopathies, people that have something called Wilms tumor, intestinal angiodysplasia, congenital heart disease, people with pesticide exposure, uremia, lupus, erythromatis, autoimmune lymphoproliferative disorders, myeloproliferative disorders, okay? So basically, it's secondary to a particular condition, okay? And it resembles von Willebrand's disease. And so the pathogenesis of acquired von Willebrand's disease may involve a decreased count of or a decreased production of von Willebrand's factor. It could also involve the adsorption of von Willebrand's factor to abnormal cell surfaces. That's mostly seen in lymphoproliferative disorders and Wills tumors. Or which is not very common, you may also see a specific von Willebrand factor autoantibody, okay? So these are acquired conditions that may come from other disorders that this resembles von Willebrand's disease, but it's not quite von Willebrand's disease because von Willebrand's disease is inherited, it's congenital. This is an acquired von Willebrand's disease, all right? So I have a summary here of the different conditions that we talked about. I didn't put the acquired, the auto, I did put the factor inhibitor here, but not acquired von Willebrand's disease. So when you look at a table like this, when you look at the disorder, the bleeding symptoms, where it's coming from, just make sense out of it, because you need to really understand what the PT is testing for, what the PTT is testing for, what the thrombin clotting time is testing for, the platelet count, right? What does it mean when it's normal? What does it mean when it's decreased? What is the mixing study? What does it mean to have a correction? No correction, okay? Factor 8 and factor 7. Now, when we talk about the different factors, and when we tell you normal, decrease, increase, we're talking about the levels of activity that the factor has, and every factor has a different level reference range, all right? Every lab will vary a little bit too, but so for instance, factor 8 may be somewhere between 50% to 130% or something like that, right? Factor 8 may be between 37%. So it all varies a little bit, but when we're looking at a factor assay, we're determining the level of activity, and it's always in the reference ranges, it's always reported as a percentage. Okay. Bethesda titer, Bethesda assay is very important for the factor antibodies or factor inhibitors, more specifically the factor 8 inhibitors. When do you use a Bethesda assay? When do you use a D-dimer? Okay. When would you go ahead and look at the liver function tests? All right. So that's also very important. So also determine whether or not the patient is on, oral anticoagulants. With a patient that has vitamin K deficiencies, how would that affect the patient in oral anticoagulants? All right. So I'll move on to the congenital coagulopathies. So these are the inherited forms, okay? So the inherited bleeding disorder. So one major inherited bleeding disorder is von Willebrand disease. Von Willebrand. I'm sorry, I spelled that wrong here. That's not supposed to have an R here. It's just supposed to be Willebrand. So I'll fix that later on. So von Willebrand was first described by a professor. He was from Finland, I believe, and his name is Erik von Willebrand. In 1926, that was when it was first discovered. And it is the most prevalent inherited mucocutaneous bleeding disorder. Okay, it's the most prevalent inherited mucocutaneous bleeding disorder. And so there's a lot of mutations that may cause von Willebrand's disease. And these mutations can either cause quantitative or qualitative von Willebrand factor abnormalities. Okay, so quantitative is usually known as type 1, and qualitative is more functional. It's known as type 2 von Willebrand disease. I'll talk about that in a little bit. Okay, both of these, though, quantitative and qualitative abnormalities, lead to decreased platelet adhesion to the injured wall vessels or vessel walls, and it impairs primary hemostasis, right? Because remember, what's the major function of von Willebrand factor? Von Willebrand factor is to adhere to that site, right? To that injured collagen that gets exposed in the blood vessels. So if we don't have enough of it, or if we don't have high quality von Willebrand factor, the platelets cannot adhere. So this is an issue with primary hemostasis, okay? This disease is impairing primary hemostasis, okay? So it's not, you know, when you look at it in the world, you know, in our population, you know, it affects, it's not something that it's affecting everybody. It's an autosomal disorder. It's found in only 1% of the population, in the global population, okay? But, you know, it's prevalent, okay? And it could be dangerous because it's a bleeding condition, okay? It's said to be common in group O individuals, more common in them than other blood groups, but you know, that's because it's said that that group O people have less von Willebrand factor. So we have to look at different we have to look at the parameters and testing guidelines for von Willebrand, and all of that is actually established by the National Heart, Lung and Blood Institute, the NHLBI. And so they let us know, so these are the parameters, these are the tests that you need to look at to diagnose someone with von Willebrand disease. So when the von Willebrand factor is at less than 30%, then it is obvious that the patient will have some mucocutaneous bleeding, easy bruising, the presence of petechiae, so that little small tiny dots of blood into the skin, epistaxis, menorrhagia, which is increased menstrual periods, the flow, very high flow, gastrointestinal tract bleeding, hematemesis of vomiting blood, and surgical bleeding, which is bleeding from surgical sites. Okay, so that can also be it could be dangerous. Okay, and if with von Willebrand disease comes a decrease in factor VIII, okay, then you see more severe symptoms. So you can see more anatomical bleeding as well. And that's because von Willebrand factor usually binds to factor VIII. So I'll talk about that in a little bit. So once you see that the levels are starting to become decreased, then there's an issue with, you know, with factor VIII as well. Okay, so we all know, we've gotten to know von Willebrand factor pretty well, I think, right? We know it is a multimeric glycoprotein. It has a molecular mass, it's a large protein, okay? The molecular mass is about 500,000 to 500,000 to like 20 million deltas. Is crazy, okay? And it's the largest molecule in the human plasma. All right, its plasma concentration is about 0.5 to 1 milligrams per deciliter. And a great deal more is readily available on demand from storage organelles. So where do we store this? So we know the von Willebrand factor is synthesized in the endothelial cells. Is actually made in the endoplasmic reticulum of the endothelial cells, and it is stored in their cytoplasmic Weevil paddle bodies. That's where they store it. It's also synthesized in the platelet, in the megakaryocyte, and stored in the alpha granules of the platelet. So we talked about that when we did the very beginning of platelets, right? The Weevil paddle bodies and the alpha granules release von Willebrand factor in response to a variety of hemostatic and inflammatory stimuli. All right, so again, keep in mind, von Willebrand factor is a big protein. It's made primarily in the endothelial cell. It's stored in the endothelial cell, but it's also synthesized in the platelets and stored in the alpha granules of the platelets. So you have von Willebrand factor that's coming from the endothelial cell, and you have von Willebrand factor that's coming from the alpha granules of the platelets. Okay, but it's a large protein. Now, we need to get to know about von Willebrand factor because there are different conditions other than just von Willebrand disease that we are going to be learning about. So there is a protease called the ADAMTS13, ADAMS 13. You could call it ADAMS 13 if you want. So this is a von Willebrand cleaving protease. It actually comes in and it cleaves the ultra large multimers of the Weevil paddle bodies at their moment of release into monomers of various sizes, because you can't really have it where von Willebrand circulating like this large molecule, right? So this protease comes in and it likes to cleave it. It cleaves it into a nice monomer. So each von Willebrand factor monomer has 4 functional domains that bind to factor 8, glycoprotein 1B95, glycoprotein 2B38, and collagen. So we'll talk about that in a little bit, okay? So once it gets released from storage, von Willebrand's factor forms a complex with factor 8. And again, von Willebrand's factor has protective mechanisms for factor 8. So when we have an issue with von Willebrand's, we may also have an issue with factor 8. So that's a picture of von Willebrand factor. Again, it's stored in the Weevil pallid bodies and also of the endothelial cells, and also in the alpha granules of the platelets. That's just something to always remember, because when we're talking about hemostasis, especially in the formation of that primary plug, it's coming from the endothelial cells endothelial cells and from the platelets, okay? And again, on demand, the Weevil paddle bodies and platelet alpha granules fuse their respective plasma membranes and release von Willebrand's factor into the bloodstream. The ultra-large multimers of von Willebrand factors are uncoiled in response to the shear forces of the blood flow, where they will be cleaved by the enzyme ADAMTS13 into shorter multimers, or the monomers, okay? The these shorter multimers will bind to the platelets. So each von Willebrand factor monomer has 4 functional domains that bind to factor 8, glycoprotein 1B95, glycoprotein 2B38, and also collagen. So it has domains and binding sites for specific receptors, okay? And obviously, as soon as von Willebrand's factor is released from storage, it will find factor 8, and it will bind to factor 8 because it needs to protect factor 8. So, so there are epitopes. If we're looking at it from like a molecular point of view, the von Willebrand factor monomer, it has epitopes of structural domains that are in this von Willebrand factor monomer that support different functions. Okay, it supports its various functions because yes, the primary function is to bind and adhere platelets to the site of injury, but it also has other functions, one of them being a protective, big brother for factor 8. So I'll show you here in yes, right here in this particular one. This is a picture of the von Willebrand's factor monomer, okay? So the von Willebrand factor gene is located on the P arm of chromosome 12, and it is the template for von Willebrand factor propeptide, okay, of 2,813 amino acids. So basically what happens here is that this monomer consists of 12 subunits within the 4 domains, okay? So there is A through D domains. So you see A1, A2, A3, there are D domains. So these 12 subunits that you see here support the active sites at the locations that are showing you here. So they support binding sites for factor A, glycoprotein 1B95, a site for cleaving, right? So for Adams 13, this is the cleavage protein, for collagen, and for glycoprotein 2B3A. Okay, so these monomers polymerize to form multimers of various lengths that reach up to 20 million deltas in molecular weight. So these monomers can repolymerize to form these high molecular weight von Willebrand factor multimers. And these are the ones that are usually very, very big. So again, although it protects factor A from proteolysis, its primary function is to mediate platelet adhesion to the subendothelial collagen. Von Willebrand's factor first binds to the collagen exposed. The platelets adhere through their glycoprotein 1B95 receptors. The platelets become activated and express a second von Willebrand factor binding site, which is glycoprotein 2B3A. This receptor binds von Willebrand factor and fibrinogen to mediate platelet-to-platelet aggregation. Adhesion and aggregation steps are essential, obviously, for normal hemostasis. So in terms of the deficiencies, well, again, we talked about von Willebrand's disease being two different main categories. We talked about the quantitative deficiencies and the functional deficiencies, the qualitative deficiencies, right? So normally the type 1 and type 3 are the quantitative deficiencies. So basically a decrease in the number of circulating viable von Willebrand factor. So type 1 von Willebrand's disease is actually the most common type. It happens in about 70 to 80% of cases. And the patient will see a slight to moderate decrease in von Willebrand's factor. So the activity gets decreased to less than 30%. But the structure of it is normal. So it's not an issue with the structure. It's more of the circulation, the amount of circulated von Willebrand's. And that's an autosomal dominant condition. Type 3 is also a quantitative deficiency, but it's a very rare condition. Type 3 is not seen very often, but this is when there's an absolute absence of von Willebrand's factor, and it is the most severe form. This is inherited in an autosomal recessive manner, and a patient can be homozygous for this genetic condition or a compound heterozygous. In terms of the structural deficiencies, we're talking about more qualitative, right? So these are autosomal dominant deficiencies, and these are the type 2. So type 2 von Willebrand's disease is related to the function of von Willebrand's factor, okay? So type 2A, not very common, but it's more common than all the other ones, of course, but it happens in about 10 to 20% of cases. And in here, you have mutations in the A2 domain that make von Willebrand's factor more susceptible to proteolysis by ADAMTS13. So remember, that protein, that proteolytic enzyme basically comes in to cleave it, right? To cleave the multimer into the monomers, okay? But because of this mutation, you now have a more sensitive A2 domain. So if I go back to this, you see that the A2 domain has a binding site for that proteolytic enzyme, right? So in type 2, type 2A von Willebrand's disease, this is just, it has this binding site, right? There's genetic mutation makes it more susceptible to proteolysis by ADAM13. So the high molecular weight and intermediate multimers are actually absent in the plasma in this particular type of von Willebrand disease. Type 2B is rare. You have mutations in the A1 domain with high affinity for binding glycoprotein 1B95. Large multimers of von Willebrand's factor bind platelets in circulations, and these large complexes adhere to the endothelium. Large multimers are absent in the plasma. Type 2M is rare. Von Willebrand factor here has defective binding to platelets, and 2N is also rare. And here's when von Willebrand's factor is defective in binding to factor VIII. So you will also have lower factor VIII levels. So here is some of the nomenclature of factor VIII von Willebrand factor complexes that you will see, not so much, I think, in like your regular coag lab, but more of like the specialized labs or labs where we do more, specialized coag testing. So von Willebrand factor is not quite tested in every place, but maybe in like a reference lab like Quest or LabCorp, where they have special coag and they can batch, samples, you would see this type of nomenclature for testing. So when you see factor VIII / von Willebrand factor, that's a designation for the combination of factor VIII and von Willebrand's factor. I think you already know that. Factor VIII is factor VIII. When you see von Willebrand factor AG, okay, that is an epitope that is the antigenic target for the von Willebrand factor immunoassay. All right, so it's von Willebrand factor antigen. Von Willebrand factor factor VIII and C, it's the factor VIII coagulant activity as measured in a clot-based assay. So sometimes you'll see that as the name of the test, okay? Then you've seen some of these already. Von Willebrand factor RCO. This is a quantitative ristosine cofactor activity, also called the von Willebrand factor activity. Von Willebrand factor activity is measured by the ability of ristosine to cause agglutination of reagent platelets by the patient's von Willebrand's factor. You have von Willebrand's factor CB, which is a collagen binding assay, a second von Willebrand factor activity assay, von Willebrand's factor immunoactivity, von Willebrand's factor GP1R. So these are different tests, RIPA, that you can do to assess the levels and the function of von Willebrand factor or the function. Also, in the differential diagnosis of von Willebrand's factor, first of all, the personal, family history is going to be very important. Assessing the activity of von Willebrand's factor is also going to be very important as well. You want to take a look at the platelet count. It's usually normal, but in type 2B, it gets decreased. The platelet function analyzer, closure time, bleeding time, yes. I mean, you can use it as a screening test, but it's not really used to rule out von Willebrand's disease. And okay, so the APTT, well, in von Willebrand's factor, von Willebrand's disease, remember, it's a carrier of factor VIII. So when it's bound and it is good, it will extend the half-life of factor VIII. But if von Willebrand's factor is decreased, then factor VIII will be decreased, and that's going to increase the APTT. Okay, so we want to assess the activity of factor VIII as well, because that can give us some indication of von Willebrand factor activity. So in type 1, factor VIII activity will be decreased, type 2, normal or slightly decreased, but in type 3, it is absolutely decreased. The PT and the thrombin clotting time can be normal, okay? So there is a standard von Willebrand disease task panel. We want to assess the quantity of it and also the functionality of it. So we can do the, I'll show you here in the next slide. And I talked about this briefly in our last lecture. We can do the von Willebrand's factor activity for a functionality assay. So we can do the ristosine cofactor assay, which tests for the ability of von Willebrand's factor to bind to platelets glycoprotein 1b95. Or we can do a quantitative assay using the von Willebrand's factor antigen immunoassay. So we can do ELISAs or automated like this agglutination, and then we can determine the ratio. So basically, we'll determine the level of activity over the antigen, which is basically the functionality of it over the quantity of it, right? And depending on the results, if the levels are greater than 0.5 to 0.7, we may be dealing with a quantitative abnormality in which there is a balanced decrease, of both, or if it's less, a qualitative abnormality, okay? Because then that would mean that the antigen is present, but it is not functional, if the ratio is decreased. Okay, if the ratio is over 0.5 to 0.7, then we're suspecting more of like a quantity issue of von Willebrand's factor. Okay, because now we have a decrease. It looks it's reflecting a balanced decrease of both. And we can also assess for factor VIII activity. We talked about this before as well. Ristosine cofactor assay will test for the ability of von Willebrand's factor to bind to platelet glycoprotein 1b9, 5 receptors. Here, there's substitution of formalin fixed or lyophilized normal reagent platelets for the patient's platelets. We call it the von Willebrand factor activity assay as well. And this is when the reagent platelets are being used. You can call it the Ristosine cofactor or the Ristosine cofactor assay or the von Willebrand factor activity assay. And so you take the patient, you prepare the patient's platelet poor plasma, you mix with reagent normal platelets and add Ristosine and perform optical aggregometry. Yields a proportional relationship between von Willebrand's factor activity and the aggregometry response to the reagent platelets. And then you compare the aggregation results for the patient's platelet poor plasma with those with the standard dilution of normal reagent platelet poor plasma, which gives a quantitative expression of the von Willebrand factor activity level. For von Willebrand's disease, we can also use the multimer analysis. And so this is by sodium sulfate, the polyacrylamide gel electrophoresis. It differentiates between von Willebrand's disease subtypes 2A and 2B. We don't really do that in our routine labs, but in reference labs, you can find that this test is done, probably with batch testing. And so, yeah, there are some limitations to this test. Von Willebrand factor activity, again, is influenced by the ABO blood type, inflammation, hormones, age, physical stress. Those are some of the things that could affect the level of activity. And the test has poor reproducibility. But there's other tests that we can use to have better precision. We can also use a von Willebrand's factor collagen binding assay, which seems to be a little bit better than the activity assay. But the multimer testing is again done by gel electrophoresis, not something that we do commonly in our lab, but it can be sent out. So you can see here the large multimers and small multimers over here, and you have a control here, the normal control. Type 1, von Willebrand's disease type 1, you'll see a diminishing concentration, right? But a normal ratio of multimers. In type 2A, you see an absence of large and intermediate multimers. In type 2B, you see the absence of large multimers. And in type 3, right, you see the absence of all multimers. So that's really bad. So anyway, so just a way of determining the von Willebrand factor multimers that can be done. And this is a summary of the lab results that can be done and what it would look like with all the different subtypes of type, of von Willebrand's disease. And then there's the von Willebrand factor activity to antigen ratio and what that looks like, and how different that is from the qualitative and the quantitative disorders. All right, so how do you treat von Willebrand's disease? Well, type 1 and type 2A subtypes can be treated with desmopressin acetate. This will initiate the release of von Willebrand's factor from platelet organelles so that you have more von Willebrand factor available. And that's not the case. That shouldn't be used for types 2B. Type 3, which is the most severe form, there is commercially prepared human plasma plasma derived high purity preparations that are available that provide a mixture of von Willebrand's factor and factor VIII. So we can use that to treat patients that have the most severe form of von Willebrand's disease. Okay, so the next inherited conditions that we'll talk about, bleeding disorders, are the hemophilia A, the hemophilia. So we'll talk about hemophilia A, B, and C. Hemophilia A is also known as classic hemophilia, and this is where the patient has a factor VIII deficiency. Hemophilia B is also known as Christmas disease, and this is where the patient has a factor IX deficiency. These are X-linked recessive disorders. 30% of factor VIII deficiencies are new mutations. The patient will have issues in which they will experience anatomical bleeding in any location, hemarthrosis, bleeding, articular bleeding, bleeding into the joints. That's very common. Carriers may be difficult to detect by doing just the factor VIII activity, since factor VIII may be increased in certain instances like pregnancy, the use of oral contraceptives, exercise, inflammation. So we don't always know when one is a carrier. Remember, this is an X-linked disorder, so females have the 2 X chromosomes and males have the XY chromosomes, right? So anyway, factor VIII levels can also be lower in group O individuals, and the ratio of factor VIII to von Willebrand's is also decreased in carriers. So women who have affected sons are considered women who have affected sons are considered to be obligate carriers, and we can use molecular tests to detect the genetic mutations in these carriers. So again, this is the way that these X-linked inherited disorders are expressed, right? Males have the XY chromosomes, females have the XX chromosomes. So male hemizygotes whose sole X chromosome contains the factor VIII gene mutation experience anatomical bleeding, but female heterozygotes who are carriers, they do not experience anatomical bleeding, okay? So males that have it, that have the gene mutation, won't experience the symptoms of the disease, but not females who are carriers. So when a female carrier has children with an unaffected man, okay? And so over here, you have a female carrier with a male, right, who is unaffected. The chances of hemophilia A inheritance are 25% chance of a normal daughter, 25% chance of a carrier daughter, 25% chance of a normal son, and 25% chance of a hemophilic son. And you have all sons of men with hemophilia A, and non-carrier women are normal, and the daughters in this case are obligate carriers of the disease. So again, all the sons of if you have a hemophilia A male, right, and you have a woman who is a non-carrier of the gene, right, will have all sons who are normal, but the daughters, okay, will be obligate carriers. So that's what an obligate carrier is. All right, so let's talk about these conditions. So we know hemophilia A is a deficiency of factor VIII, and hemophilia B is a deficiency in factor IX. And so there's 3 different categories that pertain to both of them. There's severe forms of hemophilia, moderate, and mild. And so again, when we look at the factors, we always assess the level of activity, and that's usually given to us as a percentage. So that's what you're looking at. You're looking at the percent level of activity of the factor. So severe forms, either one, factor 8 or factor 9 deficiencies, are at less, these factors are at less than 1%. And so when you know there's factors at very low levels, then there are a lot of issues, right? Because you need these factors to form that fibrin clot, and these are major factors. So the symptoms include frequent spontaneous muscle, joint, and intracranial bleeding, profuse bleeding after trauma, minor surgery, or tooth extraction. The moderate levels are between 1 and 5% of the factors, and that includes some muscle and joint bleeding after minor trauma, excessive bleeding after a minor surgery, and tooth extractions, and no spontaneous bleeding. With mild, that means that the factors are about 5 to 30% in concentrations, and there is bleeding after trauma, after major surgery, after tooth extraction, but there is no spontaneous bleeding. So basically, the only one in which you would see spontaneous bleeding, and it's very frequent, it's in severe hemophilia A or hemophilia B. So it's nice to be able to tell. The only difference here is that, there's a factor 8 deficiency and a factor 9 deficiency. So we know the PT is not going to really be affected, but the PTT is going to be prolonged, and the thrombin clotting time is going to be normal. The mixing study is going to show you a correction immediately, and then after incubation. Platelet counts are unaffected. Your factor assays are going to be playing a very important role here, because you have to assess the level of activity. So with factor 8 deficiency, you could either have severe deficiency, moderate, or mild. With factor 9, severe, moderate, or mild as well. So that's, again, going to come from assessing the factors by doing a factor assay. We can also do an immunologic test with the factor 9 or factor 8 assays. Oh, there's a typo here. You should put factor 8 here for me, please. And hemophilia C is also called Rosenthal syndrome. This is factor 11 deficiency. It's inherited in an autosomal dominant manner, and there is mild to moderate bleeding symptoms. This is mostly found in the Ashkenazi Jew population. However, there are other individuals of other ethnic backgrounds that are also affected with a factor 11 deficiency. And so we use the frequent plasma transfusions to treat patients with this. Lab tests will include a prolonged APTT, a normal PT and TCT, a mixing study with correction, a normal platelet count, but then issues in the level of activity of factor 11. All right, now, the only thing that we need to keep in mind is that the amount of factor 11, the amount of activity that we find when we do that factor assay doesn't usually correlate with the bleeding symptoms. So with hemophilia A and B, we can sort of correlate the amount of factor that we have with the bleeding, right? With severe, moderate, mild, but we can't really assess that so much with factor 11 deficiency. So what are some of the treatments? Well, for factor 8 deficiencies, we can use factor 8 concentrates like recombinant or plasma-derived concentrates. They should be monitored with the factor 8 assays. You can use desmopressin, DDAVPs. And for patients that actually have factor 8 inhibitors, you can use large doses of factor 8 concentrates, activated PCC, and recombinant activated factor 7, or also known as Novo-7. For factor 9 deficiencies, you can use factor 9 concentrates, recombinant or plasma-derived. You can monitor that with a factor 9 assay. For patients that have the factor 9 inhibitors, we can use PCC or recombinant activated factor 7. And so recombinant activated factor 7 will pretty much try to coagulate, bypassing the need for factor 8 and factor 9. In factor 11 deficiencies, you can use fresh frozen plasma, or also known as FP24. The treatment is not usually monitored since the symptoms don't really correlate with the amounts of levels that the factor is at. So you just have to pretty much keep treating the patient until the patient is well. There are other single factor deficiencies, but they're just rare and caused by autosomal recessive mutations. So one example of that is the factor 13 deficiency, in which you would see a normal PT, APTT, and TCT. You can't really test factor 13 deficiencies with these routine clot-based assays. So you can use a chromogenic or a chemical-based functional assay or immunoassay to test for factor 13. Also, there is an increase in clot solubility in 5M urea, but the test is not sensitive enough to be used all the time. And here is a summary of some other rare congenital single factor deficiencies that that you may see in some of the symptoms and therapies here. So afibrinogenemia, there's no measurable fibrinogen whatsoever, that's factor 1, and there is severe anatomic bleeding here. The patient can be, treated for this to try to raise the level of fibrinogen that they have. Prothrombin deficiency, factor 5 deficiency, factor 7 deficiency, factor 10 deficiency. These are all rare inherited single factor deficiencies that may occur. And again, the way that we know is the levels of activity. Whether you're doing a factor assay or you're measuring in another way, it's how much of that factor is present, okay? And so for most of these factors, it will correlate with the amount of bleeding. Some of them you don't, but some of them you do. So that's useful because you can always assess when you're monitoring after therapy. All right, so in summary, bleeding, hemorrhage, could occur in localized areas, or it can be generalized, okay? It can be bleeding that's acquired or bleeding that's congenital or inherited, okay? There can be anatomic soft tissue hemorrhage and systemic mucocutaneous hemorrhage, okay? Acquired bleeding disorders or hemorrhagic disorders are diagnosed in the hemostasis lab. And, we can look at the platelet count, thrombocytopenia, different etiologies, the acute coagulopathy of trauma shock, anemia, liver disease, renal disease, vitamin K deficiency, acquired hemophilia, and von Willebrand disease. These are all acquired hemorrhagic or bleeding disorders. Von Willebrand disease is the most common congenital bleeding disorders, and the diagnosis and classification of the type and subtypes requires a series of clinical lab assays. And the hemophilias are rare congenital single factor deficiencies that cause moderate to severe anatomic bleeding. And the clinical lab plays a key role in the diagnosis, the classification, and the treatment monitoring of this hemophilic patients or hemophilia disease. Okay. Are there any questions so far on this?
No, I think I'm good.
Okay. Was I recording? Oh, yes, I was. Okay.